Hello guys, welcome to my channel. Today we will focus on nephrotic syndrome. Let's get started. Nephrotic syndrome. Definition. Nephrotic syndrome is a clinical condition characterized by massive proteinuria, greater than 3.5 grams per day in adults, hypoalbuminemia, generalized edema, hyperlipidemia and lipiduria. It occurs due to increased permeability of the glomerular basement membrane, leading to excessive loss of protein in urine. Causes. Primary, idiopathic, causes. Diseases originating in the kidney. Minimal change disease. Most common in children. Focal segmental glomerulosclerosis, FSGS. Membranous nephropathy. Membranoproliferative glomerulonephritis. Secondary causes. Systemic conditions affecting the kidneys. Diabetes mellitus. Systemic lupus erythematosus, SLE, amyloidosis. Infections, HIV, hepatitis B, malaria, drugs, NSAIDs, gold, penicillamine, malignancies, lymphoma, pathophysiology. Glomerular damage increases permeability of the basement membrane. Large amounts of plasma proteins, especially albumin, are lost in urine. Hypoalbuminemia develops due to protein loss. Reduced plasma oncotic pressure leads to fluid shift into interstitial spaces, right-pointing arrow edema. Liver compensates by increasing protein and lipid synthesis. This results in hyperlipidemia and lipiduria. Loss of immunoglobulins increases risk of infection. Loss of anticoagulant proteins increases risk of thrombosis. Signs and symptoms. Edema, periorbital edema, especially in the morning, pedal edema. Generalized edema, anasarca, ascites and pleural effusion. Urinary changes. Frothy or foamy urine, decreased urine output, oliguria, other symptoms. Weight gain, fatigue and weakness. Loss of appetite, increased susceptibility to infections. Possible hypertension. Thromboembolic events, e.g., renal vein thrombosis. Diagnosis. Laboratory investigations. Urine analysis. Massive proteinuria, lipiduria, fatty casts, 24-hour urine protein, greater than 3.5 grams per day. Serum albumin, decreased. Serum cholesterol and triglycerides, increased. Blood urea and serum creatinine, may be elevated. Other tests. Renal biopsy, to determine underlying cause, immunological tests, ANA, complement levels, ultrasound of kidneys. Treatment. Medical management. Corticosteroids, especially in minimal change disease. Immunosuppressive drugs, cyclophosphamide, cyclosporin. Diuretics. For edema, ACE inhibitors or ARBs. Reduce proteinuria. Statins. For hyperlipidemia. Antibiotics. For infections, anticoagulants. If thrombosis risk is high, dietary management. Moderate protein intake. Low sodium diet. Fluid restriction if severe edema. Low-fat diet. Nursing interventions. Assessment. Monitor vital signs, especially blood pressure, daily weight measurement. Assess edema, location and severity. Monitor intake and output. Observe urine for frothiness. Care and management. Administer medications as prescribed. Elevate edematous limbs. Maintain skin care to prevent breakdown. Encourage rest during acute phase. Provide infection prevention measures. Education. Teach low-salt diet adherence. Explain importance of medication compliance. Instruct patient to report signs of infection. Educate about fluid balance and daily weight monitoring. Prevention. Early treatment of kidney and systemic diseases. Good glycemic control in diabetes. Avoid nephrotoxic drugs. Prompt treatment of infections. Regular follow-up and monitoring. Patient education on lifestyle and medication adherence. Thanks for watching. Kindly consider subscription.